Hello, Ms. Lodge. How are you?
Doing really well today, and the sun is out.
Yes.
Yes, and it's warm where you guys are, relatively speaking.
54.
Yeah, that's fabulous.
And my car needs a bath really bad. So
I know the feeling.
Take mine with you.
I think everybody in Rockford does, you know.
Hello, Richard. How are you doing today?
You're on mute.
And there's Tim. Tim, are you on mute?
I don't know. I'm
Nope.
fine.
No, Tim's not
How's
on mute.
everybody?
Good, how are
Good.
you?
Good.
Yeah.
Ash Wednesday, I see the ashes on deck.
No,
Remind-
don't tell him, but there was a bird out there. Just don't tell
Harry always has a good one, right?
him. Oh, yeah. Zingers. I'd get it from my dad.
Well, we have a few minutes, so.
Okay. Anybody want to do any stand-up comedy? Go ahead, Tim. Your turn.
Tim, do you want to compete with that, Terry? And
Tony, how's this new position going?
me, it's going really, really well. And thank you for asking. It's exciting to really, it's given me the opportunity to read a lot and to really look at potential grants that really fit more of our mission or a vision of what, like today, Jason invited me to speak about 988. So I just really am passionate about that and really wanting to see how we can evolve and serve the most vulnerable individuals in our community. So it's been really exciting. So, thank
well,
you.
that's what we're all about, Joan.
That's right. Doing God's work every day.
That's right. How are you, Brandy?
Good.
Good, nice to see you. And Bill just came on. We just have another minute or so.
Are you keeping up with everything?
Pardon me?
I was asking Chelsea if she's keeping up with everything.
Oh, yeah. She is.
Believe me, she does.
Hi,
She's keeping up.
Good
She's
afternoon.
probably ahead of
Yeah.
all of us, not just. keeping
Thank
up.
goodness.
Hi, everybody.
hello.
Hi, Jeanette. How you
Jeanette.
doing?
Good
I'm
to
great.
see
How are
you.
you guys?
Good.
Good.
Hanging in there.
Am I late?
No, you're actually just perfectly on time.
Okay.
Your timing's impeccable.
Thank
Mhm.
you.
Mary Ann, you might want to tilt your screen just a little bit.
I know, I've tried. It's, you know, when you're, oh, now, thanks a lot, Dick, for this. Now, let me get back to Yeah, it's hard. See, I need another cushion in the chair, you know? That's what I need.
Telephone books, Marianne, but they don't
Yeah,
make.
I need that too, because where this chair is so low that it's not even funny. I might sit on a book.
I don't think they make telephone books anymore, though.
Yeah. How's that? Better?
Well, you have to sit there.
You can see my mouth now a little bit. Oh, goodness. Well, I'm going to go ahead and call the meeting to order. And I'll take a call at this point. Dick Kunert,
Here,
Dr. Copeland,
Here.
good afternoon. Nice to see you. Dr. Gorski,
Here.
Dr. Giardini. We know Terry. Terry,
Asleep.
present.
You're muted.
Yes, I'm sorry. Sorry, yes. Sorry.
You've been talking all before.
I
the
know.
meeting.
I thought this was a good way to keep me from talking.
Okay, that's good. Now we miss when you're not talking. So,
Okay.
Kim Neighbors,
Here.
Linda Sanquist, not here. Wendy Larson Bennett. Okay, and our advisory members, Jay Ware and Jeanette Towns.
Here.
Okay. We actually have no public comment that I was made aware of. Jason,
No one has signed up.
okay, thank you. And we do have one presentation courtesy of Joan Lodge from Rosecrans. So Joan, I'm gonna give you the floor.
Thank you, Mary Ann. Again, I want to thank the Mental Health Board and Jason's invitation to present to you today. I have a PowerPoint presentation as well as a brief video that I want to share too. So I'm going to share my screen. Okay. So what I'm presenting to you today about is the 988 system, crisis care system that has gotten a lot of questions. I'm trying to do my best today to really paint a picture of what that will look like. I need to preface that it is not my opinions or the opinions of Rosecrans. It really has to do with information that I obtained from the 988 stakeholder meetings, DMH learning collaboratives, and lots of reading. So what is 988? And why is it needed, really? And many of this will not come to a surprise to you as the Mental Health Board because of the needs assessment and things that you've already done throughout our community, but it's still a problem within our nation. So suicide is the second leading cause of death among young people and is the 10th leading cause of death in the nation. And one death by suicide happens almost every 11 minutes in the United States. Approximately 1 in 5 people above the age of 12 has a mental health condition in the United States. Suicide is the leading cause of death among young people and the 10th leading cause of death overall. And then this is pretty staggering. More Americans died from mental health crises and substance abuse in 2018 than have died in combat in every war combined since World War II. So 988 really is, so again, why is it needed? Sorry. So it's 988 is really meant to be more of like a crisis continuum. So it just gave you some statistics about suicide, but what we know to be true is that it can be preventable and mental health conditions are very treatable. And so more than ever, our community and our nation must come together to really update our behavioral health system because the way that we've been doing it really is not working as people in crisis and ours continue to be in emotional distress. But we have to evolve and we have to meet the needs of those people in crisis and distress. And also we have additional issues that have come up with the pandemic, opioid crisis and things like that have really combated the problem even more. So there must be a shift from our existing behavioral health crisis care continuum toward a system that is inclusive, person-centered, and cross-collaborative. And that is really very much the crisis continuum that 988 holds to be true. So the mission and vision. So SAMHSA was really the spearhead for this vision, and they solicited Vibrant Emotional Health, which is a Mental Health America affiliate. And they are actually the administrator of all the National Suicide Prevention Lifeline call centers. So they developed a vision and a mission for 988. And 988 serve as Americans' mental health safety net, and we will reduce suicides and mental health crises and provide a pathway to well-being. The mission, everyone in the United States and its territories will have immediate access to effective suicide prevention, crisis services, and behavioral health care through 988. SAMHSA takes this vision and mission a little bit farther in terms of their mission is really about anyone, anytime, anywhere. So anyone meaning an adult, a kid, a person with substance abuse problems, mental health problems, DD, a veteran, anyone, person regardless of funding source. So why now? Why can't we just continue to do what we've always been doing? Well, it's been because, so again, it's some data and reports from 2019 that the average 10% of law enforcement agencies' total budget and 20% of their time is spent responding to and transporting individuals with mental illness. So a fully implemented, and I underlined and highlighted fully implemented because this whole crisis continuum really is a continuum. And there's pieces that have not been created or developed yet. So once it's fully implemented, 988 will reduce avoidable emergency department or hospital admissions for people in crisis and avoid traumatic engagements with the criminal justice system. So I really want to show you, and hopefully I can pull this off, a brief video. Can you see that?
I can't hear this.
No,
Can anyone hear it?
no.
I can't either.
Okay, hold on. Okay, hold on. Now I have it going, but you can't hear it. We won't do that today. And I apologize for that. Technology.
It's great when you know how to work it.
It is. Let me try again.
I don't.
We do it all the time.
I know, but we really need it.
All right, we're back. It'll be in your presentation and I can send it to Jason for you guys to look at in your own time period. So this is what the roadmap really starts with. And so it starts with there's been a lot of planning that's been going on. So in July of 2020, the FCC already had designated 98 as this new 3-digit code for the National Suicide Prevention Helpline or Lifeline. So the 988 will be that direct line to trained national suicide prevention counselors. So they will be the ones that will be responding to the phone calls that clients receive who are in distress and need a mental health response. So when that, and they've already done some preliminary data about how many calls and volumes that this will look like. So in 2020, they already received nearly 2.4 million calls. And so the intent was, if the ease of a really 3-digit number should be very simple, hopefully, for individuals to reach out who are in distress to call. So we identify that we need it, but then how are we going to pay for it? It's always the biggest question of the hour, right? And so the National Suicide Hotline is 24/7, 365. It's free. And it's funded through SAMHSA. And this was a big part of Biden and Harris's administration in focusing on putting money into this 988 crisis continuum. And their envision is it'd be the first step toward transforming crisis care in the country, creating a versatile entry point to needed crisis services in line with access to other emergency medical services. They're putting a lot of money in this effort. So what is it? We know it's a 3-digit number that those calls, when someone will call and be answered by the National Suicide Crisis Hotline. So feedback has been that thousands of people call this line every day and that they feel better when they call, right? And they are all trained and have best practices. So when this goes into effect is really in July of 2022, where all telecommunication companies will have to make necessary changes so individuals can access that 98 dialing code. So again, the 98 individuals are highly trained. They indicate that about 60% of the calls are able to be really handled, but they might need something a little bit more. Many people feel good of just being able to vent, feeling validated, giving, empathy and support and skills over the phone, but some of those individuals might need a little bit more of a response. DMH predicts about 70 to 90% of callers, their needs can be met over the phone. But what do you do with those percentages that can't? So the new Lifeline holds the promise of equitable healthcare. The promise can be fulfilled if adequate resources are put into place for the continuum of care. And this is a big push towards also being able to have individuals who have that lived experience to be trained to help to respond to some of the crisis needs of the clients that are calling. Best practices. We know Mental Health Board expects best practices from the programs that you fund, or evidence-based practices, as well as the crisis continuum. These core principles were identified and adopted by the crisis call centers and the individuals who are providing the care in the continuum. So remember I talked about the percentage of people that could be managed over the phone and handled by the crisis call center. 60 to 70% of those can, but some of them might need a little bit more. So what was involved in that is then the crisis Lifeline call centers dispatch local mobile crisis teams. So the intent about that is that it'll be a mobile crisis team going out to do a welfare check perhaps, or an in-person contact with that person. Instead of us, how we used to always do things, is we would do a welfare check and we would send a police officer to the person's home. So this is a different part of that vision of that crisis continuum. So the mobile crisis teams would be dispatched, and they would have a clinician and an individual with lived experience, or an engagement specialist is what DMH is calling them, who would respond in tandem to every call or to every home visit wherever that person potentially could be, any location where they're at. And the intent of that is to address whatever the crisis is, develop a plan for safety and for follow-up, and then connect them with necessary services, which that might look like referral to the living room, might be, hey, taking them over to the triage center or to the crisis stabilization unit, crisis residential. Again, the intent is to only on those rare occasions would you need to contact law enforcement to have the person transported to an emergency room. To make the crisis continuum even more expansive, many of you have probably heard of CESA. So CESA is an act, it's called the Community Emergency Services and Support Act. It was a House bill signed by Governor Pritzker in August of 2021, not that long ago. And this was based on an incident that occurred with a 15-year-old boy who had Asperger's. His parents were really concerned about his behavior. He had a knife. The officers were called to respond to the home. Reports indicate that the child got combative or whatever that looks like, and they shot and killed the child. So this House bill, CESA, is really to promote and protect the health and safety and welfare of the public. So what CESA looks at is how to really include the 911 system within this whole crisis continuum. So there's a lot of work that still needs to be done for CESA. At the DMH level, the Secretary's office is working on a statewide advisory committee, and then we'll work with each of the regions' EMS or 911 dispatch system to figure out how that will all coordinate. I think the intent really behind it is when those mental health crisis calls go through, funneled through 911, then the dispatch is going to make those decisions whether or not they need to go to 988 or maybe directly dispatch to a mobile crisis team. But the marching orders for that is no later than January of 2023. So what's the recap? The goal of 988 is the crisis line to connect people who are in mental health crisis to trained counselors, reduce the healthcare spending, reduce the use of law enforcement, meet the growing need of the crisis intervention where the client is at, and help end stigma towards seeking, accessing mental health care. And I love this, when you've got police or fire or rescue, you call 911. When you have an urgent mental health need, you'll call 988. So there's a lot that still needs to be done in terms of organizational communication, community communication, because if you'll notice, many times, even in medical facilities and doctors' offices and things like that, they'll say, I'm currently out of the office. If you have an emergency, please hang up and call 911. And that's really what we're trying to avoid. So I'd be happy to take any questions that anyone has.
I have a couple for sure, but go ahead. Who else has any? Wendy?
No questions.
Okay, Tim.
I have a few. How, well, since this is Rosecrans and you work with the co-responder program, how would this work with the co-responder program?
I knew that was going to be a question today. I think, and those are conversations that I've had with the EMS and dispatch, and I think how it will work, or how I would envision it to work, is that I think the model of care is to reduce a law enforcement response at all costs. But there will be some incidences where that's really just not going to be possible. Or we may have a history with a particular individual where we can make that mobile crisis team response, but maybe we need an additional support. Doesn't need to be full on 911 or, fire and everything, but maybe some additional supports where those were. I think that's going to be impacted more from CESA, because that's when CCRT really is dispatch is based from the 911 call center. And then they go out based on those calls.
And when the crisis team is dispatched, is this a different crisis team other than the co-responders from the program, from the co-responder program, or is it the same team?
No, it would not be the same team as co-responder program. This would be a mobile crisis team separate from that DMH is partially funding.
So when you say DMH is funding, this would be something that's not from the mental health, the 1% sales tax?
Correct.
Then the other question is, since the addition of the 988 3-digit code to call, and I see the co-responder program is asking for nurses in there to help dispatch, how would this be any different from them asking for those nurses, and would it help us prevent them from having to request those nurses in the 911 center?
I'm not sure I know how to respond to that. I think that there is a medical component that is very, very valuable to tease out whether or not when the mobile crisis teams go out, if that's is something that might be beyond their scope of practice when they're dealing with. For example, you have a person that might be complaining of anxiety, so that's a completely appropriate mobile crisis response to go out, help a person deal with their panic attack. But then when you get there, you find out that they have uncontrolled diabetes that might potentially be impacting that. So I think that medical oversight is incredibly important. I think we can be utilized, maybe mobile crisis teams use telehealth and communicate one-on-one to the EMS in the dispatch for some guidance like that.
I guess my real question is, they say that the dispatch person doesn't have the capabilities of delineating between sending someone different other than the 911 response personnel, fire, and police and co-responders. So I want to know, how would a dispatch delineate the difference between calling the emergency unit versus sending them to the 988?
Mm-hmm. And that's what the regional planning and the state at the state level have to make those decisions yet. They haven't even been, those stakeholder meetings I'm not even certain that they have started.
And my last question, if they do call 988, would they be able, and it's not a crisis, would they be able to call 988 without it being a crisis, just to be able to find services in the Rockford area?
Sorry, I didn't realize I didn't have my video on. So how it would work is, like, let's say a person from this area calls 988, and then what our responsibility is to make sure that our resources are up to date and communicated to the call centers. So when they're getting calls, they can provide adequate and appropriate community resources to the person based on their catchment area.
Okay, Jeanette, go ahead.
Do the callers have to give a lot of personal information before they can receive any help, or can it be anonymous? And do you require their address?
So I think there's a couple different things that you're asking. One, I think it can be anonymous. I think the challenge will be is if your call is going to require or best practice would be requiring a mobile crisis response team to come to your home. We would need to know, or the crisis call center would need to know where you were located in order to dispatch the local crisis team to where you were at.
Well, Joan, would you utilize the same technology that 911 has? Which does.
The call centers are working on boosting their technology, because if you think about it, many people's mobile phones, right? We don't usually have a landline like we used to. And landlines were easy because the 3-digit prefix of your area code basically was where your region or where you lived. Now we have people that have 779 phones. Well, where is that at, right? So there's a lot of technology that needs to happen at the crisis line level to make sure that when they're dispatching those teams or providing community resources, they are where that person can get to and locate it.
Thank you, Joan. You know what? This is getting too long a segment now. Our attorney's on the phone or on our meeting, and we need to get to that piece of it. But the only suggestion that I have, Joan, it's not fully implemented. It'll be very confusing for the client right now. We hardly have the co-responder program out the door and people understanding fully where to call and how to access. And it's a lot of duplication of service and a lot of duplication of dollars spent in the same area for our region. So I think you should take all of that into consideration for communities that already are such as ours that are doing our kind of co-responder. I think it's got to be streamlined more, but anyhow, I just had to add that so you can take back to your planning board and kind of let them know that piece of it.
If
Okay.
you have any other questions, just let Jason know and I can respond to them as soon as I can.
Okay, Joan, thanks
you
so much
posted.
for the
Thank you, Ms. Lodge.
presentation.
You're welcome.
It was really important
you.
for us.
It's always good to see everyone. Thank you.
Bye-bye.
Thank you, thank you, thank you.
Okay, so I think we'll just jump on down. Can we change the agenda then, Jason, and let the discussion take place, or should we just proceed? as
No, we can
normal?
proceed with the current order because our legal counsel, Brandy, will be able to speak to a few of the agenda items today.
Okay, very good then. We'll just move on down. The monthly activity report, you all received that in the packet of the board meeting. Jason, is there anything you
We don't
want?
need to take too much time on that today. I'll just,
Okay.
we're just moving through the grant review process and you can review that on your own time.
Thank you. And we have a couple of action items, the first being the minutes for the February meeting. So I'll need a motion for approval.
I move so that the minutes be approved.
Okay, a second.
Second.
Thank you, Bill. And any discussion or any further corrections or additions? Okay, hearing none, I'll take roll call. Dick Cooner?
Aye.
Okay, Dr. Copeland,
Aye.
Dr. Gorski,
Aye.
Dr. Giardini,
Aye.
Tim Neighbors. Aye, did Tim say aye? Okay,
Aye.
Linda Sandquist, Wendy Larson Bennett,
Aye.
and Mariana Body, aye. Okay, so we will then move down to the updates to the bylaws, and I know that the attorney will be able to help us with this, but Jason, do you want to take the?
Yeah,
first
sure. I'll
page?
just set the stage with
Yeah.
the continuation of our conversation last time through that the change in the bylaws has not changed the intent or purpose of the bylaws in any way. It is simply getting the bylaws completely aligned with the Community Mental Health Act now that the Mental Health Board has that statutory authority based on changes that were made to the sales tax law that now connect that directly to the Community Mental Health Act. On the issue of advisors, that will be addressed in the policies and procedures, which will be part of the discussion for today. But it was recommended by legal counsel that that not be included in the bylaws. But should the board wish to include a definition of advisors, that could be part of policies and procedures. And I'll let our legal counsel now answer any questions that you might have on that.
Yeah, just to briefly add, the bylaws are more of the structure of the entity. So it is a broader document just as to how the structure is and how the organization is run, the statutory authority. And so then anything that is going to be a little bit more movable go into the policies and procedures. That way the bylaws don't have to change. And if we need to update policies and procedures, we can certainly do that.
Okay, any other questions for Brandy? Hearing none, then,
I make a motion that
okay,
the changes and the updating of the bylaws be accepted by the board.
okay, thank you, Dick. Do we have a second to that motion?
I'll second that.
Thank you, Wendy. Any further discussion? Hearing none, I will take roll call. Dick Cooner,
And
Dr. Copeland,
Aye.
Dr. Gorski,
Aye.
Dr. Giardini,
Aye.
Tim Neighbors,
Aye.
Linda Sandquist, Wendy Larson Bennett,
Aye.
Mariana Body, aye. Okay, thank you for that. And now moving into our discussion items. First is policies and procedures. Jason?
Yeah, so currently the board has two policies that have been adopted. One is a funding policy and the other is the anti-retaliation policy, which was passed through resolution. So I believe it is the intent that both of those could be included in this. Is that correct? And then in addition to that, there was the question from the board in last conversation if we should also create some type of policy and procedure or definition of the role of the advisor. And so I'll leave that, maybe turn that over to Brandy for her review of that.
So I did take a look at the statute and also the initial documents by the county setting up the Community Mental Health Board. And even though the county board has created this position of advisors, there really isn't any statutory authority for them. So generally for a governmental entity, you only have whatever powers that are given to you by statute. It's called Dillon's rule, in case anyone's ever heard of that before. So the issue with the advisors is when it's not part of the statute, but yet we're treating it as not a board member, but as a member of the board or belonging to the government entity, then we kind of raise some fuzzy issues like, is this person subject to OMA, the Open Meetings Act? There's some FOIA issues. Are there communications subject to FOIA? So it's this, like quasi board member, government employee type situation that we don't know exactly where we stand on it. Obviously, the conservative thing to do is if you do incorporate the advisors into the structure and the policies and procedures, then it would be probably prudent to make them subject to, the Freedom of Information Act, to treat their correspondence that way. Some of the issues are they're not, because it's not an official position, they're not subject to like the Public Officers Prohibited Activities Act. So they could, for instance, they could advocate for a funding partner that they would have a personal interest in, and by statute, there's no accountability there for that. I do think that there is a vital role in having advisors to a board, in situations where you do need expertise or something like that. And then there's also really, in terms of the accountability, there's also, I'm not sure exactly what the county board's intent is as to control over these advisors. I don't know, if there is an appointment of 1 year or if they're appointed the same term limit as the actual board members. And then also, there's the county board chair they appoint the board members, but they can also remove them from the board. For the advisors, there's really no clear intent here as to whether or not they can be removed. So we're kind of making up the rules as we go along if we do continue to have these advisors. So if you have any questions, I can certainly answer or try to answer those for you.
I have a question. Brandy Gorski here, and I'm sorry, Jeanette, just one quick question. Well, maybe it's not quick. Can the policies and procedures, with all of the things that you have mentioned relative to the distinguishment of that status versus a board member, can the policies and procedures mimic everything that the board members are subjected to, including terms and OMA and the right of the chairman to appoint and to terminate, with the exception of voting rights? Can it be mimicked with that exception?
We can certainly do that, but there's always a question of if there's actually no statutory authority for an advisor position, then what enforcement do we have for this? So we can certainly have the advisors, potentially even have them sign some sort of an agreement that they will be subject to this. But outside of the contractual agreement, then we as the board would have no authority to enforce these rules and laws.
Well, I think the biggest thing out of this position was to broaden the expertise of the board in specific areas. You know, we often will have people, well, like Joan, just coming in today and giving us her expert information about something that interacts with the mental health board's
Right.
area of concern. But, you know, Joan has other job responsibilities. So I wouldn't expect that she would show up at every board meeting. On the other hand, having someone, let's say like Jeanette, who has lived experience in this area, offers us ongoing important insight. And I think that was the aim behind the idea of an advisor, that there's someone who's made a commitment to the mental health board as an entity who brings some unique skill set to the table. And I think that's an important role for the board to embrace somehow in a way that is subject to the same constraints the board members have. So the same ethical constraints. And maybe a contractual arrangement is the simplest way to do it, as opposed to us just saying, oh, by the way, you're subject to the same stuff we are.
Jeanette, you had a question.
Yes, I did. If I were asked to do a public speaking engagement by someone who is receiving money from the board, would it be a conflict of a conflict of interest to receive a stipend?
Say that again, if you were asked to do a public speaking engagement to who?
Okay, I'm a public speaker.
Mhm.
If someone who is receiving money from the board, like an organization, if they were to ask me to do a public speaking engagement, would it be a conflict of interest to receive a stipend?
No, and part of it is because you're not a voting member of the board. It's sort of a gray area. You're not voting on a contract that the board would be entering into with like one of your funding partners. So there wouldn't be a conflict in that way. There could be a conflict if you are advocating for a group to be a funding partner, and as part of their program would be to hire you on as a speaker to go out to different organizations and speak on their behalf. That's more of not necessarily a statutory conflict, but still a fiduciary conflict.
Thank you.
So I have a question. Given the statute and now with our legal authority, does the chairman still have the obligation to even appoint advisors, or would that be removed from the expectation?
I think that it is questionable that whether or not the chair, I don't think it's questionable. I don't think that the chair has the statutory authority to do that, but we are acting as if he does. So if it's going to continue, then I would say perhaps we need to address it in the policies and procedures.
Okay.
I,
Any other questions?
Yeah, just one for Brandy. So it's a little unclear to me, Brandy, and I know from a legal perspective, you're just giving us information rather than necessarily a recommendation, but say that if it was the board's, if just hypothetically, theoretically, or even in reality, it was the board's desire to continue with advisors, is it doable? Appropriately documented, contracted, is it doable?
Yes, I think it is.
Okay.
Is it
I think the best way to do that would be to contractually obligate them to the freedom of information, or to the board under the statutes, or like you said, mimicking the statutes that you have obligations under.
Thank you. Got it.
Anyone else?
I got a question or a statement, not necessarily to legal, but to the board. When I was talking to the chairman and it was discussed, not necessarily with the whole board, but with some members of the board, that they don't like the idea of having an advisory member on the board, especially for such a long time. And they said they understand advisory members being on the board if it was a specific project and the advisory person be on for 3 months or so to help with a specific project in a particular area. But they was hoping that the mental health board would get rid of the advisory board position.
So in your opinion, Tim, is the chairman going to continue to appoint advisors or not? I mean,
He's looking at the statute just like we're looking at the statute. And, you know, from their standpoint, the mental health board shouldn't have an advisory member. So that's as far as we got with that. But it's a conversation we're still continuing to have.
Why were they against it?
For some of the same reasons that Brandy had initially stated, and it said it's just advisory members should be someone that the other thing that I remember exactly why they didn't want the board to it said it's preventing the board to be totally transparent on who can be eligible to become members, and they didn't like the process of the board member having an advisory member and then moving up to become a board member. That's keeping that's saying to the public that you have to be a part of the group already. And you know, like, it prevents people from the opportunity to be, when they weren't able to be on the board at a specific time, and then later on down the road they are available to be on the board, then it prevents us to put the better person on the board at that specific time.
Dick?
So we could make a policy to use ad hoc advisors related to particular issues, correct?
Absolutely.
And so with that policy, for example, we could, make time and make each temporary appointment to that as an advisor to the board, given a certain amount of time to fulfill whatever project we're talking about. Would that work?
Yes.
Okay.
So Dick, when would there not be a time that we need advice from a person with lived experience?
I think the issue is the one that Tim brought up, Mary Ann, that again, that lived experience advisor could also then be given a time period to give their advice, which means that there then could be a rotating. We could give invitations to different people to their input in like what their contribution might be. Because the only impediment that I'm hearing from Tim coming from the chairman is, again, not wanting a permanent advisor to our board, with the implication that's a step toward succession to being a board member itself. And so it seems to me that we can create a policy that would allow us to use advisors with different kinds of skill sets and experience. But we just simply would frame it in ways that where we're specific about the particular expertise that we're seeking, and that we put a time period around it.
So at this point, it's still in our discussion stage. We have two advisors that, have been appointed. And so we'll have to discuss going forward how this would be handled, because I think it's definitely for futuristic. We now know that the expectation would be different, but what about current board, our advisors? Are they grandfathered in? Is that such a thing? Or is this something that we have to make a decision on as to time, term limits, length of time?
It was discussed that the current advisors are grandfathered in, and when their term is up, that we just don't add any more advisors.
So that's your understanding that the chairman has?
Yes.
Okay.
But we don't, Marianne, we don't currently have a time. There's not a term, is there, for the advisors, or is there? No.
No, that is very true, because, they're appointed, but we all have certain number of years. But the advisors have not fit into any timetable.
And make that part of our policy.
And
Okay. I mean,
okay,
that, that again, what it would simply mean would be that, current advisors are the first incumbents in meeting our policy, but that a time period would be given to their period of service.
okay.
Something else that the board might consider would be creating, just for our edification, sort of a community advisory group, which would have a similar aim, which is to broaden our knowledge base about what is and isn't going on in the community, or what is and isn't necessary. Since, amongst us, we have a fair amount of expertise, but we certainly don't cover the entire ground that exists. So just something to think about.
Right. And there are 10 separate groups that are doing. Jason right now is, working on this, because there are 10 groups that are meeting about or around mental health issues, some children, some adults. So, I don't know if that's futuristic for, to have those groups give, input. I don't know. Jason, do you want to comment on that a little bit? Because I think that's important knowledge that you have about those groups.
Yeah, I think there's multiple groups convening around mental health issues. I think each of them have a little bit of a different flavor. I would say that most of them are groups of organizational stakeholders and not driven by the end user of the system, the lived experience perspective, aside from maybe the youth mental health system of care group, which I think has actually made its steering committee up of the lived experience perspective. So that's kind of part of the analysis that we're doing right now in terms of the development of a systems coordination plan, to try to better think about what it means to either link with these groups or to convene our own group and whatever that needs to look like. So I do think there needs to be more conversation about that, but I think it can be part of our broader conversation of systems coordination, which will quickly follow our funding decisions this year.
Bill.
I think that's a good spot for us to
I agree.
end, I guess.
Bill?
I'm really struck by what Tim said after his conversation with the chair, and then Dick's reinforcing comments. I think my personal opinion is need to be careful that there is the either appearance or reality of a closed loop of pipeline to become a board member. That certainly could be true of the advisor position. It certainly could even be true of a smaller number of advisors, whether formal or however, that if not a part of this, then why even bother, putting forward your interest in becoming a board member? I think we need to be careful with that. Personally, I would be very supportive of this notion of grandfathering with a term limit, and then maybe ultimately seeing how that fleshes out in the future, where the role just goes away. And because I think it's a community manifestation of community membership, we need to not put any barriers in place to qualified people wanting to ultimately put forward their name to be on the board.
I agree with that 100%. So if there are no further questions for Brandy, I think that's the last piece of the agenda that we needed her for. Is that correct, Jason?
I have asked her to stay for the entire meeting, so.
Oh, okay. I'm not trying to get rid of you, Brandy.
Be available
I
for any
understand.
questions we have when we reach other matters. I know there was.
Oh, very good. Yeah, that's good.
Something timely for our discussion today.
Okay, excellent. Thank you so much for being with us. So we're now on to the branded apparel, and this is it's a discussion item. Terry has been spearheading. Chelsea she's the expert, I think, in recommendations. So Jason, how do you want to approach
Sure,
this?
if I could, I'll set the stage and then I'll let Chelsea speak more.
Okay.
To it. Essentially, we've had conversations over the past year and a half about the idea of getting branded apparel, and Terry was going to just get himself a sweatshirt, and that was fine. We tried to help him coordinate that by providing logos, but the complicating factors became essentially, the minimum order that's required for some of these places. And so, and then also, getting the colors and everything to make it look very official and consistent with the logo. So as we're looking at what community engagement looks like for the board moving forward, and certainly as COVID restrictions are reduced and there's greater opportunity for us to be in the public and do community engagement events and maybe get a booth and things where we can be out talking to the public, we thought now would be as good a time as any to have the conversation about maybe ordering some branded apparel as part of our community engagement budget for board community engagement, official board events where board members would be present, engaging community to be clearly and transparently identified as a member of the Winnebago County Mental Health Board with a branded Winnebago County Mental Health Board apparel and logo. So Chelsea, if you want to maybe speak to just the initial discovery you've done and then get some board feedback on that.
So I had spoken with Dave Mays of DRM Promotions that was recommended by Terry. And so through the conversation with him and then through my own experience of doing apparel orders myself, the best recommendation for me would be that we would go with embroidery. As you can see behind me, we have the two versions of our logo. And so we would have base products that be white or navy. And if we went in a screen print route, it cost multiple, there's like a bracket or tier system where it costs more for multiple colors. And if we went in an embroidery route, it wouldn't matter what color the base product is. And then it would just be stitching, and also the product itself through wear and wash. Embroidery would maintain higher quality of product. I've had a screen printed polo that is faded very quickly. So in looking through and communicating with Dave, I came across Sanmar, which is a kind of like a base product website. And from there, I had looked into making sure my recommendation would be a white polo. And I made sure when I went through all the product items that it was a higher weight, so would not be a see-through polo. And in the packet, it showed kind of demonstrated what it would look like. There's a female cut and a male cut. And those base products on Sanmar, it may depend on the vendor, but that is a lower cost item. And then for the pullover, it would be a quarter zip. That again, the base product is lower cost, but it has a nice collar as well. And so then I'd be able to work with whoever does the embroidery, be able to get the stitching as accurate and close to our logo. And I have list of other vendors in the areas I just looked up on the website, but if there's any other recommendations, and there's a draft of a request for quote. And so those are my recommendations, and I am open to questions.
So, I guess, so are we putting this out for bid, like to get 3 different quotes?
Mhm.
That would be the intent, Tim. Yeah, we do it through our procurement here and do it at least 3. I think we have a list of maybe 6
There's-
vendors.
Yes.
We're
And I
talking
don't know if all the
local
vendors.
vendors,
Yes, I did
Local?
local. And I don't know if all of these vendors have the capability for what I'm requesting, but I would reach out to all of these, and if there's any additional ones that I don't include, because I'm not familiar with all of the opportunities in the area, I'm definitely open to sending it out to all of them.
Yeah, Embroidery just does our shirts and they do a good job.
Yes, they're on my list.
I saw it.
Yes.
They're pricey though.
Question about Chelsea or Jason or anyone. What is our intent of the span of customer base for this apparel? Is it board members? Is it public? And what would you envision be the magnitude of an order of this type of apparel?
Just for board members, for community engagement events.
That's all. Okay.
Yeah.
Nice job, Chels.
Well,
Looking forward to seeing
Yeah,
it.
so this is not an action item for today. We are taking board member
Right.
feedback, and then we'll
Okay.
get the quotes, which can then be
Okay.
added as an action item.
And
the
this
next
is
time.
a credit to Terry's persistency. I'm
Yeah.
telling you. So when we're all wearing,
Hey.
sporting our,
I just brought it up, thought, what the heck? Why
I
not?
know.
Take a
I
stab
think
at
that-
it.
That's
You
good.
know.
That's fine.
And Chelsea actually has done a great job.
You have. Yeah,
Good for you, Chelsea.
Thank you. It was good timing too. So
good. All right.
Thank you.
Any further discussion? All right, moving on. The other agenda item is other matters. And I had a brief conversation with Jason today. And the governor's emergency open meeting, whatever you call that, it was, he declared that, during COVID, that we would not meet in person. But there's a very good likelihood that he is going to stop the mandates, and actually we would have to meet in person for the open meeting. So that could happen as early as April. Am I stating this correctly, Brandy and Jason?
It would actually, if the governor does not renew the most recent proclamation, it would end on Sunday,
Okay,
March 6th. So I guess your next meeting would be in April, correct?
mhm.
So you're right. So the next meeting would be in person.
Gosh, we'll really get to see what one another looks like.
So
In
that would
2
be
years.
at R1.
You look taller on TV.
Yes,
Jason,
we have a board-
is that going to be at R1?
Yes, we have a board room that is able to accommodate the size of the board and also offer still for us to live stream it on Zoom.
Okay.
Or on YouTube, sorry. through Zoom on YouTube. So I think one of the considerations is, essentially that is my understanding, the governor was doing these disaster order renewals on a month-by-month basis. So I think aside from waiting for him to stop, the question is, does it make sense to go to in person? Otherwise, each month we're going to kind of be waiting to see if it gets renewed to determine for the next month, should that even be extended.
Well, obviously, I think we're moving towards in-person meetings. My only question would be, because I'm very skittish about this, as you know, last night before the State of the Union, they had every congressman and House representative test before they went in, and 4 Democrats were positive and they had no symptoms. So, I'm thinking, well, if we're going to go into a room, do we want to do a rapid test before or not?
Well, since we all should have or be eligible to get tests, my suggestion is that we test the day before, and those tests or the morning of.
The day of, really.
Yeah, and prior to showing up in person. That's certainly not burdensome.
I'm in favor of that.
It would be reassuring.
Yeah. So I'm going to make that in the form of a motion that prior to the in-person meeting, we all agree to test that morning to ensure that we're COVID negative.
It's not on the agenda for action.
Right.
It
Oh,
wouldn't be
okay.
able to be a motion.
All right, so we'll lay it over till next month.
It's a request. It's a request.
Yes. Okay.
And Attorney Quince, could you maybe, what is the current ability for, should somebody test positive, their ability at that point to participate virtually if everyone else is in person, and also if the disaster order ends?
If the disaster order continues, we can continue to meet remotely as we have. And we'll probably know that by Friday. If the disaster order does not continue past Sunday the 6th, then the Open Meetings Act does provide that a quorum has to be physically present. It will allow for members to participate remotely if there's a quorum physically present. If someone has a personal illness or disability, if your employment or the board's business takes you away and you can't attend, or if there's a family or other emergency. And generally the way it works is you contact, in this case, probably Jason, to say that you have one of these situations, and then the board would make a motion at the meeting to allow you to participate remotely. And that would be either video or audio.
Okay. Sounds good. All right. Any further discussion on that? All right. The last item on the agenda, of course, is Dick's responsibility. It's adjournment. I need a motion.
Except you're muted, Dick.
You're muted.
Yes, I would like to make a motion that we adjourn.
I'll second.
Thank you very much, Bill and Dick. So roll call for that is Dick Hooners,
Aye.
Dr. Gorski,
Aye.
Dr. Copeland,
Aye.
Dr. Giardini,
Aye.
Tim Nevers,
Aye.
Wendy Larson Bennett.
Aye.
Mary Ann Abadi. Aye. Linda Sandquist. So, thank you all very much.